Today we are going to discuss myofunctional appliances. Myo, as you understand, myo means muscle, and the appliances which utilizes the muscle function to elicit the response or make the changes about in the jaws is known as myofunctional appliances. The philosophy of orthodontics was during across the Atlantic Ocean between World War One and Two, that is between 1920s and 1930s, was divided between the North America and the Europe. North American subcontinent was um, was being dominated by Edward H. Angle, which once said modestly to Frederick Noyes that I have given you an appliance and now use it. Whereas Europe was having two basic appliances, which was using two basic appliances, which is removal appliance. Another was activator. Now, activator is an myofunctional appliance, whereas the all removal appliances are like active plates are used as removal appliances. There was nothing very new about removal appliances, but activator was like something which was being given by Anderson and Carl Hubble. Now, let us know what an appliance do to the jaws. To let the appliance dictate the method of the objective of the treatment is poor orthodontics. Like you are having an appliance and you're trying to fit it into a particular mouth and a particular condition in a particular malocclusion. This is not the way. You should choose an appliance according to the condition which is prevailing in the for every malocclusion, for every type of cases. You have a different appliances and their functions in detail before you put two orthodontics. The term functional appliances refer to a variety of removable and fixed appliances designed to alter the arrangement of the various muscle groups that influences the function and the position of the mandible in order to transmit the forces to the dentition and the basal bone. That is, because of the change in the position of the mandible, the muscle goes into a stress, and that stretch leads into the formation of a potential energy, and that potential energy tends to affect. That energy is tends to apply forces on the dental arches and the jaws as well. Now, mandibular lengthening by functional appliances, is it a myth or a reality? Now, it is very important that the form and the function is the backbone of the functional therapy. That is, that the function governs the form, not the form governing the function. There is a pendulum swing from the non-extraction treatment to extraction and then back. That is, initially in Edward H. Angle time, there was a non-extraction was predominantly was practiced, and later it was a shift to extraction. And now again in present era, that is up to say 1990, there is again a paradigm shift on the towards the non-extraction condition treatment options. Now there is a genetic paradigm which should always be taken into consideration. Not all cases we can convert into a, but we can alter by means of an appliance. So genetic predilection should always be seen. So we have to see whether the parents are having the same type of a malocclusion, or their fathers or grandfathers was also having their particular type of a genetic pattern. So that has to be always kept into the mind. And this is a new, not, I will not call it a new thing, but it is there which is taken given more importance nowadays. Now the role of the condylar cartilage, condyle of the mandible, which is articulating into the articular into the glenoid fossa of the skull, of the skull, or the temporal bone has a cartilage over it. Now, this cartilage is comparable to a cartilage over your long bones, that is epiphysis. The condylar cartilage, by and large, is a secondary cartilage. I'll come later on in my presentation what is the difference between a secondary cartilage and what is the difference between a primary cartilage. Now, there are two basic cell varieties, the skeletal cells and there are prechondroblasts. Both these cells are originating from mesenchymal tissues, and there is no secondary ossification center in the in the mandibular condyles, and it is responsive to the mechanical stimuli. Now, since it is responsible to the mechanical stimuli, hence it can be changed. And this is the basis of the whole myofunctional appliance therapy. Now, the role of the condylar cartilage condylar cartilage does know how the mandible grows. And it is the mandible which determines how the condyle is going to go. See, mandibular growth in turns is determined by the factors outside the mandibles. This statement was given by Melvin S. Elmos, whose theory was that the form is secondary, mechanically obligatory, and compensatory to function. Now, the condylar versus epiphyseal cartilages are condylar cartilage is secondary in nature, and whereas the epiphysis is primary in nature. Now, why we call it secondary? The secondary in just because this is not in the primary cartilage in the jaws is basically is embedded in the middle layer. That is that in the primates, that is in the reptiles, the jaws are basically opening and closing jaws, and the movement, the lower jaw and the mandible, maxilla, or the upper jaw are having a primary contact. But in the process of evolution, that primary joint is got embedded into middle layer inside the skull, and there is a second functional alteration or adaptation occurred, and a secondary joint was being formed, and that is why the condylar joint is known as a secondary joint. And the epiphysis of a long bone is a primary joint. This is under the influence of the growth or growth hormones. Now, the growth in the condylar cartilage is peripheral. That is, it on the outer surface, there can be increase in the layers or modification can happen. Whereas in the epiphysis of the long bones actually lengthens by means of the interstitially, that is from inside to out. Whereas in condylar cartilage, it is from outside to in. The maturation, there is no secondary centers in the condyle, whereas in the long bones, that is epiphyseal areas, there are secondary centers where the ossification occurs. Now, to the stimuli, to the mechanical stimuli, the condylar cartilage hence is responsive, whereas in epiphyseal cartilage, it is non-responsive or unresponsive. It is directly under the influence of the genetic part, predilection of that particular individual. That is, that particular individual, as he has got the genetic makeup, he will grow the same height and the same pattern. Whereas the condylar cartilage atypically behaves to the hormonal changes, whereas epiphyseal are directly under the control of the hormonal changes. That is the somatomatic hormones, that is the growth hormones, has direct effect on the epiphyseal. Now, the classification of the myofunctional appliances, given by T.M. Braber were group A. These are teeth supported appliances. Now, teeth supporters are Catalan appliances, inclined planes, That is, this particular appliance is being fixed over a tooth, whereas teeth and tissue supported group B is teeth and tissue supported, that is activator and bionator. Group C is the vestibular positioned appliances, that is, it is isolated from the tooth and tissues, ex example frontal and the lip bumpers. That is, it is utilizing the muscle, direct muscle function or direct muscle, it is removing the muscular effect from the jaws and letting it grow normally. Abnormal muscle function, that is. With the advent of the fixed functional appliances, that is later on further modification was been done in classifying the myofunctional appliances. These are removable appliances. Removable, as it can be removed by the patient. They are activator, bionator, and Frankel. There are semi-fixed functional appliances which cannot be removed fully by the patient. These are Denholz and the Bass appliances. And there are fixed functional appliances like Herbst, Jasper Jumper, Safe Springs, Eureka Springs, Mandibular Interior Repositioning of Springs, and Clapper's Super Spring, Savag's Universal Spring. These are different type of the fixed functional appliances. With the concept of the hybridization, which was given by Peter Wick, functional appliances can be further classified into classical functional appliances, which is given similar to that what has been given by Anderson, Haupel, Petrovic, McNamara, so and so on. And there are hybrid appliances like propulsors, double oral screens, hybrid bionators, Bass appliances. These are modifications of the functional appliances. Now, the classification put forward, which was latest and most accepted, is by Profit. Now, teeth-borne passive appliances are myotonic appliances. Now, these myotonic appliances was given by the Anderson Howell. Now, the myotonic appliances relying on relying on the muscle mass and the resting muscle pressure. The teeth-borne active appliances are myodynamic in nature, like elastic open activator, Daimler appliances, modified bionator, and stock fit appliances. And these appliances, they totally depend on the muscle activity or the movement of the muscle to let the forces being subjected to the appliance and from there to the teeth and the jaws. The tissue-borne appliances are oral screens, lip bumpers, and etc. And tissue-borne active appliances are Frankel. Frankel appliances are basically given by Adolf Frankel, and the last is the functional orthopedic magnetic appliances. That is FOMA. Now, the treatment principle of the myofunctional appliances is depending on the type applied. The two treatment principles have been differentiated: the forced application and the force elimination. In force application, the compressive stresses and the strain act on the structure involved and resulting into a primary alteration in the form with the secondary adaptation of the function. In force elimination, the abnormal and the restrictive abnormal muscle function or restrictive muscle environmental influences are being eliminated, allowing the optimal development to occur. Now, this primarily function followed by the restoration of the form. I mean, the normal growth is the inhibited normal growth is been that inhibition has been removed in the form of the abnormal and the restrictive environmental influences, and by force elimination, the normal growth is occurring in the normal course, in the usual course. The myofunctional appliances, the mode of action, the functional appliance increase the contractile activity of the lateral pterygoid muscle. When we protrude the lower jaw, there is an increase in the contractile activity of the lateral pterygoid muscle, and this lead into intensification of the retrodiscal pad. Now, this retrodiscal pad is situated in the bilamellar zone, which is posterior to the condyle, and it has been attached to the temporal bone and to the neck of the condyle. Now, once and there is in the bilamellar zone, there is a thick plexus of vessels, and this once there is a stretching effect on this bilamellar zone, there is this increased supply, thereby bringing about us a stretch or a tension. And when there is a tension, as you know, there is a bone is apposition. Hence, there is an increased growth stimulating factor reaching that particular site because of the increased blood flow in the bilamellar zone. And this leads into the enhancement of the local mediators and resulting into the condylar growth, increased condylar growth under the influence of the functional appliance. Now, the summary of the functional appliances are: case which fits into the functional appliance therapy is the patient has to be growing in the first place, and it should have a good VTO. That it should have a retruded mandible. That is, the class 2, the factor which is contributing to the class 2 malocclusion should be retruded mandible. And there should be a horizontal mandibular growth pattern. The direction should be not vertical, should be horizontal, strictly, and relatively normal maxilla. Now, minimum lower, upper and lower crowding and proclination is expected in when we are trying to treat with the functional appliance. The mode of action of the of biomyofunctional appliances is debatable. There are school of thought which says that there is a true stimulation which occurs, which is also known as an absolute stimulation. That is, till the patient is wearing an appliance, and when the appliance is being removed, the increased amount of the growth is sustained and maintained, and thereby there is an increased lengthening of the mandible. This particular type of stimulation, growth stimulation, is known as a true stimulation. Now, the second type of the stimulation is temporal stimulation. Now, this temporal stimulation is that there is an initial surge in the growth, and as the appliance has been removed, the growth is actually comes back to the normal genetical uh, pattern or a form. So this particular type of the growth stimulation is known as temporal stimulation, which is not a true stimulation. Now, the mechanism of the mandibular protrusion is active and passive. Mechanism of the mandibular protrusion: extent of the mandibular posturing, forward posturing. That is, it totally depends upon how much amount of forward posturing you are doing. Few millimeter of activation of the mandibular musculature lead into the maximum activation of the muscle. Now, this is something which is very important. We should bear in mind that the activity of the muscle is maximum when it is not stressed to the full extent, to the full defect. Greater activation, what happens with the greater activation? The muscle gets electrically silenced, and thereby the activity is not transmit the after the muscle get electrically silenced, the activation in the muscle is reduced or becomes zero. Thereby, there is no active changes occurring during the wearing of the appliance. So that particular appliance has got no advantage in wearing when we are having a greater activation. The muscle activation not necessary for growth modulation. Now, effect of the functional appliances is, in class 2 cases, is acceleration of the mandibular growth, and then there is a restriction of the maxillary growth. That is also known as headgear effect. I'll come to it later on in the lecture when I'll explain how the acceleration of the mandible or a forward positioning of the mandible brings about a restrictive effect on the maxillary growth. And then there is a backward tipping. Simultaneously, there is a backward tipping of the maxillary incisors and the forward tipping of the mandibular incisor and the entire mandibular dentation. Now, this is known as a class 2 elastic effect. Now, last, but which is the most important, is the changes in the dentollar segment. That is the differential eruption of the teeth. That is the differential eruption of the mandibular buccal teeth or lower posterior teeth, and the rotation of the occlusal plane. That is a very important effect of the functional appliances in treatment of the class 2 cases. Now, functionally, if we see that the class 2 division 1 malocclusion are of 7 types. You can see A, B, C, D, E, F, G. In not all the cases, the functional appliance is going to be effective. Let's bear this in mind. It is not that indiscriminately where we find a class 2 division 1 malocclusion, we indiscriminately load the patient with a myofunctional appliance. If we are not properly diagnosing our cases or segregating the right case, we will not get the desired result. It is from the present slide, you can see that only D type of the class 2 division 1 malocclusion, it is apt for the functional therapy, for appliance therapy to occur. Now, the theory of the construction of the bite is that there are certain muscle reflexes. When the appliances are being worn and the mandibular forward positioning has been given, the stretch reflex has been, or which we call as myotactic reflex, is been elicited into the muscle. And the muscles has muscle spindles. Now, these muscle spindles are made up of the interfusal fibers. Now, these interfusal fibers are basically having a nucleus here. Once there is a pull of the muscle spindle, the nuclear bag is stretched and a sensory input is been given to the mesencephalic nucleus in the pons, that is the midbrain. And from there is a motor response which is being elicited, and this to the extrafusal fibers, that is the fibers out of the muscle spindle, and this lead into a contractile activity. Now, once the muscle is stretched beyond a particular limit, what will happen? The same response is going to go, but there is additional response which is gone into the Golgi tendon organ, and this silenced the muscle in the response of the excessive pressure or the stretching of the muscle beyond a particular level. Now, we cannot give an appliance without particularly registering a bite. Now, bite registration is something which is very, very important in fabrication of a myofunctional appliances, where we are going to put the till what extent should be the mandible jumping should be there, and how much opening has to be there, how much transfer corrections can be made by the appliances. Now, this has been done by registering a proper bite. Now, basic aim is to describe the position of the mandible in all 3 planes, that is vertical, horizontal, as well as transverse. Now, vertical opening is that the type of the appliance used. Now, we have with every type of the appliance and every amount, every type of the appliance which we are going to, we desire to put in that particular situation, the bite opening, vertical bite opening is different. For a tip, first we decide what appliance we are going to put, and for that particular appliance, the vertical opening is been. And the second thing is the type of the defect or dysplasia in the mandible also governs the vertical opening. Like if it is a backward rotating mandible, we cannot open the mandible too much because this is going to deteriorate the mandibular rotation. And this, if the mandible is counterclockwise rotating or a forward rotating, then we can vertically open, we can have more vertical opening. Now, it totally depends upon the age and this sex and age of the patient. Now, transfer posturing of the mandible, the upper and the lower midline coincides in the habitual occlusion. And the sagittal relationship is bilateral. No need to make any transverse compensation. That is, we can make the transfer compensation to an extent where we can coincide the midlines of, and that too in the limit of the habitual occlusion. Not beyond that. If there is a dental midline or the dental shift in the midlines, that mandibular is more towards right and the maxilla is more towards left, we don't try to correct it because that is to be corrected by individual correction of the long axes of the teeth in each jaw. Here, the mild skeletal or shift of the mandible can be corrected by transverse positioning of the mandible. Now, midline determination, for this, we have to determine the maxillary and the mandibular fault. Firstly, we have to assign where the fault lies. In this while in the mandible is more towards under the influence of the posterior inclines, it can shift a bit. Now, this midline can be corrected with appliance. This particular width can be corrected by means of myofunctional appliances. And if it is true, it is a dental midline, it has to be corrected by a fixed appliance. Again, to recap, the 6 points for the functional analysis is it has to be a growing case. We are modulating and channelizing the growth. The myofunctional appliances on bringing forward, we find that the patient profile is significantly improved. This means that particular case is only when the for. Second thing is this to be should be relatively normal. There should be
Yes, sir. So you may say now.
Should I start? Growth is it is in the pubertal phase. That is between 7 to 13 in females and 12 to 14 in males, 15 in males. and it should have a good VTO, that is good visual treatment objective. That is, when we are trying to bring the lower jaw forward, absolutely normal. And this is only possible when we are targeting the organ or bringing the organ forward that is at fault, that is mandible. Hence, retruded mandible is very important for the functional appliance therapy to be successful. Third thing, not all type of mandibular retrusion can be treated by myofunctional appliances. Preferably, the horizontal growth direction will be uh, aptly treated by the myofunctional appliances. Now, and and the backward rotating mandible will be further deteriorated by means of the functional appliances. Hence, they are not best suited until unless we make some modification to it. Relatively normal maxilla is very important because we do not want any changes in the maxilla, and the minimum upper and lower teeth crowding and proclination. That is, we don't want too much of proclination because in lower arch the proclination is going to deteriorate and the crowding cannot be relieved by the functional appliances. Hence, we want a minimum amount of crowding in the lower arch and no proclination in the lower arch. These are the 6 points which fits the case into a functional appliance therapy. Now, with this, we are going to end today's lecture. We'll get back to you next time, continuing with this myofunctional appliances. Thank you. From where we have left last time, to have a quick recap about the summary of the functional analysis. Patient has to be growing, that is pubertal growth spurt has to be remaining. Patient should have a good visual treatment objective, that is, with the patient forward positioning of the mandible should give a good and a nice profile to the patient. The mandible has to be retruded. It can only be um given in the cases where the mandible is at fault. Horizontal mandibular growth direction is mandatory for the functional appliance therapy, but it can be given in the backward rotating mandible with slight amount of modifications. Maxilla has to be relatively normal, and the upper and lower dentition should not have crowding or proclination of the teeth. Now, for the construction of the bite, patient compliance is very important. Apart from that, there has to be a clinical BTO testing should be done beforehand. Before the construction of bite is to be done, patient has to be motivated, calmed, and practiced for construction of a bite. Now, we need the study models. We need a model analysis. Molar relationship has to be ascertained. Midline has to be checked, and a symmetry of the arches should also be taken into consideration. The curvus P, not the space. Curvus P and the crowding is to be assessed in the study model analysis. The functional analysis has been done, and the supplementary analysis has to be done before we land up into construction of a bite. For construction of the bite, the determination of the mandible position, anterior positioning of the mandible with end-to-end incisal relationship. But that in an attempt to get an end-to-end relationship, we should not exceed more than 7 to 8 millimeters. Now, overjet, if it is too large, a stepwise progression is advocated. That is, Suppose it is more than 10 mm. Overjet is more than 10 mm. So we will go for 70% of the correction and rest in the subsequent progressive appliances. Now, serve labial tipping of the pre-functional appliances. Now, this severe labial tipping, we will, it is preferable to correct it by the removal appliances before giving a functional appliance. Now, the lingually placed lower incisors are being uprighted and then the functional appliances should be given. These are all pre-functional phases, which should be practiced before the functional appliances are or a construction of bite is being done for a functional appliance. Now, opening of the bite. The guiding principle for opening the bite is the mandible must be dislocated from the resting position with at least in one direction, that is either sagittally or vertically. Essential to activate the associated musculature and induce a strain into the tissue. Now, this is the basic purpose of moving the mandible from the resting position. That is, we are trying to induce a strain. Now, if the magnitude of the forward positioning is great as 7 to 8 millimeters, the vertical opening should be less, minimal, so as not to overstress the muscle. Again, to remind you, if we overstress the muscle, there will be a clasp knife reflex elicited and resulting into the muscle getting into a electrically silenced state. Now, that is, in that case, there will be a sudden silencing of the muscle or slacking of the muscle, and it is no more under the strain. Now, general rule is if the forward positioning of the mandible is 7 to 8 mm, the vertical opening must be slight to moderate. If the forward positioning is not more than 3 to 5 mm, then the vertical opening should be 4 to 6 mm. And the lower midline shift or the deviation can be corrected if there is an actual translation of the mandible itself. That is, if there is slight amount of skeletal mobilization or shift of the mandible, then only we can try to make an attempt while correcting the midline during the bite registration. Now, horizontal posturing of the mandible, the original sagittal relationship may be maintained in case with a maxillary protraction and not the mandibular retrusion. Horizontal posturing of the mandible is the forward posturing of the mandible to change the sagittal relationship equally on both the sides when the problem is bilaterally symmetrical. That is that both the side you are getting this class 2 full cusp or both side you are getting class 2 end on, then the symmetrical sagittal changes has to be asserted and the path of closure is asserted. Now, this has to be looked before the bite registration is attempted. The bite changed in one side unilateral class 2 or a class 3 condition, then in that cases the mandible changes should not be attempted. We should see if there is a natural slide during the closure, or if there is a slide due to the occlusal interference, then the attempt in changing it, changing the transverse correction should be attempted during the bite registration. The backward posturing of the mandible, that is a backward rotation of the mandible as much as possible in the fossa to try for the end-to-end incisal relationship in class 3 cases. Now, actually, we can give myofunctional appliances in class 3 cases as well. Till now, I've been talking about the myofunctional appliances in class 2 relationship. But again, in the class 3, the bite registration is done in a different manner. It is in that case, we don't bring the mandible forward. We push the mandible, that is the condyle, into the fossa and try to attain end-to-end incisal relationship in class 3 cases. Now, activators are been given. Now you can appreciate they in the second picture there is an improvement in the profile by bringing the jaw forward. Now this improvement in the profile of a case by bringing the jaw forward or while wearing an appliance is known as positive VTO. It is not deteriorating, it is improving from here till here. Now, now activators are having, there are certain uses and modification of the activators. Activators are constructed in the form of a monoblock, that is that there is an upper component and then there is a mandibular component, and both are joined together by a bridge. Now this in upper component, it is in approximation with the upper teeth, and in the lower arch we try to keep it free for the free eruption of the lower arch. Now let us concentrate only on the maxillary segment. Now you might appreciate that there are striped lines which are touching all the mesial component of the maxillary teeth. That is the mesial palatal aspect of the canine, premolar, second premolar, and molar here. And there is a space left on the distal aspect on all the teeth. Hence, this space, the significance of this space is whatever thrust is being generated here, that their teeth has to have the space for the movement of in the distal direction. And if we would have incorporated the acrylic here, the teeth would not have moved into a desired direction. In the similar manner, there has to be a relief given in this undercut area for allowing the teeth to move freely under the influence of the acrylic. Now, this whole effect is known as the headgear effect, which I have described earlier in the previous lecture. Again, I'm recapitulating that there are 7 types of class 2 division 1 malocclusion, and only one, that is D, is suited for the myofunctional appliances. To repeat, the case which fits in the myofunctional appliances therapy is the pubertal growth should be remaining. There has to be a good VTO. VTO I have already explained a couple of slides before now. The mandible should be retruded and the horizontal mandibular growth direction should be there. And maxilla should be normal. Let me go back to the last slide. Here you can appreciate that the cranium and the maxilla is in the same line and the mandible is protruded. So if the mandible is brought forward, you will get a straight profile. Here you can see that the maxilla and mandible are in the same line, but the upper teeth are ahead. So this is also a type of a class 2 division 1, or it can be a class 1 type 2 malocclusion. But in this case, myofunctional appliance is not suited because it is appliance given for the skeletal malrelationship, where there is a skeletal malformation. There only, those are the cases where myofunctional appliances are suited. Now, according to Howard Woodside activator, here he has done, if we have you see that there is a barrier between the upper arch and a lower arch, but there is a gap between the acrylic which is joining the maxilla and the mandibular component of the activator. There is increased amount of space here, letting the mandibular teeth grow forward, upward and forward, which is a natural method of growth uh, of the any teeth for that matter. Here you can appreciate the same. If if the mandibular teeth grows forward, and the resultant will be in this direction, what will happen? The automatically the mandibular teeth will come in the class one relationship to the maxillary teeth. Here you can appreciate that this particular acrylic is in approximation to the maxillary arch, and there is a mandibular clearance. Same way, in class 2, we give the, in the class 2 malocclusion, we keep the acrylic near to the maxillary arch. In the class 1, we keep the maxillary and mandibular at the similar distance. And further in class 3, we keep it towards the, um, uh, away from the maxillary arch, more near to the mandibular buccal segment. Now, the construction of the bite, extreme vertical bite opening was given by Howard Woodside, and minimal sagittal forward positioning, or you can say sagittal forwarding of the mandible is minimal, whereas the extreme bite, vertical bite opening was being recommended. The vertical opening should be was as recommended by the Howard Woodside was 8 to 10 beyond the freeway space. Say freeway space is 2 to 4 then it will be added to 8 to 10 And this brings about the elicitation or the viscoelastic properties of the muscles and bring about the changes. This brings about the passive tension. Again, this this is the maxillary arch. Again, we see that we have waxed up the distal segment of the buccal segment, and the acrylic is in contact with the mesial side. Now, this mesial side acrylic lead into the thrust onto the maxillary buccal teeth in the distal direction. Now, this lead into the movement of the maxillary buccal segment in the distal side, or in the distal direction. This is basically known as the headgear effect. Now, these are certain modification of the activator. These are propulsor pallet free activator, which was later been made more comfortable because by reducing the bulk. Some wires have been added where we can utilize more wire and reduce the acrylic component of the uh, in the activator. These are certain modification of the activators which was been given. Now there is the expansion screws been incorporated for expanding the arches, and this grid has been incorporated to avoid to as an habit breaking appliance simultaneously into the elastic open activator. Now, there is another appliance where the acrylic component is too less and there is an increased wire component. But this wire component is particularly designed in as a coffin spring in the palate. Now, this is supposedly given by for the purpose for stimulating the tongue and bring about the jaw forward. The dorsum of the tongue has been stimulated, and thereby correction of the mandible has been done. According to Balter, who was a proponent who gave the bionator, says that the position of the tongue is very important in correction of the myofunctional appliances. So the bionator has two components. First is the palatal wire, and second is the buccal shields, which keeps the buccinator muscles away from the dental arches, and leading into the expansion under the pressure of the tongue. Now, furthermore, the functional interceptor appliances are further modification of the myofunctional appliances, where function, functional uh, defects like tongue thrusting have been intercepted by these appliances along with the activator effect, along with the bite jumping. Now, these are the modifications of the bionator appliance, which reduces the bulk of the wire, the bulk of the appliance, reduces the acrylic, increases the compliance of the patient, and thereby correcting the malocclusion. Now, Bimler was a German who gave these myofunctional appliances modification, which has a lot of wire components into it. Now, his he has he basically designed his appliances during the World War II injuries, when he sees that one side of the jaw has been gone under the blast or a gunshot injury, and he has seen the other side, which was normal. The muscle in that side tend to pull the whole jaw into one direction, and resulting, say, the right upper maxillary teeth are in contact with the lower left mandibular teeth. So to correct this malformation, or this because of the scarring of the muscle, he designed the appliances. And these appliances has acrylic and the muscle uh, and the wires. Now wires, these appliances were later modified to be used as functional appliances as well. This is a picture of a Bimler appliance, which is again has a lot of wire component, less of the acrylic component, just to hold the wire, and the wire which has been used are 036 and 040 dimensions. Now, lastly, we are going to come with a functional regulator appliance. Now, this functional regulator appliance, or FR appliance, it tends to stimulate it creates a periosteal pull in the overall region and in the buccal segment, and brings about the expansion of the arches by means of the uh, pulling of the buccinator muscle and keeping at the buccinator muscle and bringing about the change in the whole arch. It apart from bringing the sagittal correction, it brings the bring about the transverse correction by means of these buccal pads. Whereas it has an additional advantage of having the keeping the lower incisal pads, or you can say the labial pads, which forces, which uh, remove or eliminate the forces of the lower lip, and let the the lower jaw being brought forward, and the changes which can occur in the desired changes which can occur by means of the functional regulator appliances. Now this, if you appreciate the F component, now this F component is a very important component as far as the sagittal positioning of the mandible. Now, the functional regulator is basically how does it bring about the changes in the by the periosteal pull. That this is basically in A diagram. You must be visualizing that this is the depth of the vestibule. This is, and this solid line is in the bony segment, whereas this vestibular area is being deepened in the models, and the appliance or a lip pad has been designed till the depth. Now this leads into the pull of the muscle, and where the muscle is, here the muscles have been attaching to the bone and bringing about this tension lead into the acquisition of the bone in the in because of the vestibular pull, and leading into the expansion or um, eliciting the changes, more authentic and more permanent changes in the uh, job. Again, I would like to summarize once again the functional analysis. The case which fits for the functional appliance therapy is a patient should be growing, be it bionator, be it functional regulator, be it elastic open activator, be it a Bimbler appliance, be it an activator, whatever appliance we are going to choose, it has to be, a patient has to be in a growing age. It has to have a good VTO. That is that the changes should be their visual treatment objects should be positive. The profile should improve uh, while bringing the mandible forward. The mandible should have the fault, and it should have a retruded mandible. The horizontal mandibular growth direction is again very important, and relatively normal maxilla has to be there. Minimum or no crowding and proclination should be there. Whereas certain amount of crowding can be relieved by the frankel appliances. Certain amount of frankel correction, crowding and proclination, crowding can be taken care by means of the frankel function regulators, and certain amount of proclination can also be taken care by this A arch wire here. But by and large, we want that it should be minimal crowding and minimal proclination. Thank you. Thank you. This is all for the day.